Now I'd like to introduce Dr. Joshua Gordon. He's the director of the National Institute of Mental Health. Please welcome Dr. Gordon. Hey, thanks for joining us. So Dr. Gordon, tell us about your agency. I'm sure many in the audience are familiar with it, but maybe people watching online, not so much.
So I am the director of the National Institute of Mental Health, as you mentioned. This is the principal federal agency responsible for funding mental health research. We're one of the 27 institutes and centers of the National Institutes of Health, and we're the largest funder of mental health research in the globe.
And you have been the director since 2016.
That's right.
What has happened in those years?
Oh my.
A lot, right? And a lot of challenges in those years.
A lot of challenges and a lot of successes. Of course, you know, we've experienced a number of challenges to the nation's mental health between the pandemic, the upheaval around George Floyd, and lots of other things. And we've all experienced that together. We've all had those mental health impacts. In terms of progress in mental health research, just in those last 7 years, we've seen the adoption of coordinated specialty care for first episode psychosis in over 300 clinics throughout the United States, serving thousands of individuals. We've seen the FDA approval of two novel therapies, two novel medications for depression. We've seen expansion of services in a variety of areas. It might sound Pollyanna-ish after what we've just heard, and I don't mean to be that way, but certainly we have seen a lot of progress in research in those 7 years.
How does it work with all the different 27 entities and coordinating government response and implementation? How do you do that?
Well, at NIMH, our role is research primarily, but we also have a responsibility to try to make sure that research meets the public's needs and is adopted and implemented. We do that in a variety of different ways. First, on the research side, we do work with the other 26 institutes and centers to make sure that we're not studying mental health in isolation, but in combination with other forms of health, whether it be around substance use, alcoholism and alcohol use disorders, cardiac health, et cetera. So we make sure to try to integrate our research in those ways. When we talk about, though, having our research reach people who need it, that's where we try to work with a broad variety of other organizations, some of whom have been represented here today on this stage, like the National Alliance of Mental Illness, where we've formed, they helped us form a public-private partnership for drug discovery in schizophrenia. We work with the Substance Use and Mental Health Services Administration, which is responsible for funding those coordinated specialty care clinics to make sure they're using evidence-based approaches there. In fact, we have a learning healthcare network we formed with them so that those clinics can learn from their experiences and figure out what's working and what doesn't work, where our researchers are embedded in those clinics, getting data from those patients and sending it back to the clinic so the clinic knows what works. We work with the FDA, CMS, et cetera, to make sure that evidence-based approaches can be approved and can be supported. So a lot of different interactions with different federal agencies.
Well, speaking of what works and what doesn't, what have you seen in research trends? What have you noticed that would be, for people here in the audience and watching online, that you've seen, wow, that's interesting?
Also, man.
A lot of stuff, right?
A lot of stuff. Let me tell you three things.
Okay.
One, from a neuroscience perspective, obviously mental illnesses, they're instantiated in the brain. Yes, lots of things in our society, in the environment affect it, but they're instantiated in the brain. And we've made just dramatic progress in the last 10, 15 years on understanding how the brain works. Just last week, 24 papers from a giant consortium funded by the NIH Brain Initiative, which is one of those collaborations across institutes, has revealed that we have over 3,000 different brain cell types. And not only revealed that we have those types, but demonstrated their complexity, demonstrated their function, and provided the tools where we can then go ask how do those differ in individuals with mental illness as compared to individuals without mental illness. And also with specific diagnoses. Thank you. I think that is important too. So that's one. Another thing, let's talk about suicide prevention, and in particular youth suicide prevention. So when I came on in 2016, we recognized, as was said earlier, that suicides have been rising over the last 20 years really inexorably. And they continuously from 2000 to 2018, we saw a dip for 2 years, and now they're rising again. So what can we do from a research perspective? Our research had shown already by 2017, 2018, that universal screening in healthcare situations, particularly emergency rooms and primary care, can double the number of people at risk that are identified, and then appropriate levels of follow-up can reduce that risk by 30%. That was all in adults. So we've now advanced that to move that into adolescents and children to show that universal screening can also work with children and adolescents. And then again, we're developing digital approaches to providing suicide prevention therapeutics that can better reach kids. So that's one trend that I'm seeing. And then the third one is really a trend where we're trying consciously to push. You know, the Biden-Harris administration released their report on mental health research priorities several months ago, and that was developed in concert with NIMH and a number of other federal agencies. But one of their cross-cutting priorities is in mental health equity. We recognize that in order to address issues of inequity in mental health, which are rife throughout our society, we need a better understanding of the social determinants of health, and we need interventions that are tailored for minoritized communities and rural communities and others suffering from these disparities. So that's been a real push over the last several years to try to develop the cadre of researchers who can do that in terms of developing training programs specifically for them, as well as diversifying our research workforce, because we've come to see that it's researchers from those communities who want to go back in, understand that problem, and develop solutions for that problem.
Has that been a positive coming out of COVID? We talked earlier about telehealth. And what are some of the solutions to reduce some of those disparities, whether it be racial disparities or rural areas?
So telemental health is absolutely key. One of the good things about NIMH research is we had been spending over the last 15 years a great deal of effort supporting research that showed that mental health delivered over the telephone, over video conferencing, and through digital apps can be as effective as in-person mental health if delivered with an evidence-based approach. That was ready when the pandemic came in 2020, and virtually everyone in mental health shifted immediately to telehealth. So we knew that it worked, and people were able to apply those evidence-based principles in the real world. One quick example with regard to equity. Researchers had been studying that transition, particularly in California, and showed that mental health care delivered via community-based mental health clinics, and these are federally funded clinics, which reach minoritized populations, underserved and poor populations, was effectively driven so that indeed telemental health not only replaced previous levels of mental health visits, but actually mental health visits during the pandemic increased, even in these underserved communities. Now, it's not perfect. As was mentioned earlier, many individuals with limited means have limited access to broadband. And so we found that in these federally qualified healthcare centers that are providing mental health, much of that remote care was via telephone. Fortunately, we know that works, but it may not be as ideal as video conferencing, which requires the greater broadband. So that's just one example of something good that came out of the pandemic. The other thing is not necessarily good, but it's helped inform our research approach. As we knew from disaster after disaster that preceded the pandemic, those with limited means, those in minoritized communities, those with poor access to mental health care are also the most affected by any emergency, and that was absolutely true during the pandemic. But the other thing that we learned from that is that social supports instituted by states and local communities helped stave off the worst of that pandemic. We did not see suicide rates rise in the general population through the pandemic. And one of the reasons we think that might have worked based upon research that's been happened so far is that there was a tremendous social welfare response in terms of easing the rules on continuing cash payments, easing the rules on food supplements, the ban on evictions that happen in many communities throughout the United States. These based on our research that NIMH supported, seem to stave off the worst.
Came up in a couple conversations earlier how we have a an aging population in this country, and there are workforce issues right now. What's the solution there?
Put very, very simply, we need to train, as was mentioned earlier, we need to train more mental health care providers, and specifically in the geriatric population. The highest rates of death by suicide, yes, death by suicide amongst youth is tragic and rising very rapidly, especially minoritized youth. But the highest rates of suicide are in the middle-aged and elderly.
And that doesn't get the attention it deserves.
No. And so we need care provisions, we need care approaches that reach the elderly as well. And we don't have enough. We don't have enough of those. I should mention, it was mentioned earlier about peers as one potential locus. NIMH has funded a lot of research on non-traditional healthcare providers. Much of it is actually funded in lower and middle income countries, where our global mental health team has been supporting a lot of wonderful research. But those findings from those communities about the use of lay healthcare workers, about the use of peer supports, these have been brought back to the United States and are being studied in our communities where we have lower resources and challenges in access.
That was one of my questions about learning from, whatever works you want to copy, right? And America is very focused on America. But what can we learn from, well, it could be states, it could be different programs that we've talked about, but internationally? Other countries, are they leading the way? Are we learning from them?
Yes, in lots of different ways. We can learn from Great Britain, which decided to adopt cognitive behavioral therapy and other evidence-based therapeutic approaches throughout their national healthcare system. And although there continue to be challenges of access, the rates at which people were getting evidence-based care dramatically increased with that move. We can learn from our studies in Africa, where we've shown that having a lay healthcare worker sitting in primary care providers' waiting rooms. They're not really rooms in many of these communities. They're benches outside of the clinic. And just talking to people can identify more people at risk. They have to be trained. It can't just be anyone, but identify more people at risk. We learned from our studies in Nepal that teaching providers methods to address mental health care problems isn't enough. But if you pair that education with experience, with conversations with people who've benefited from mental health care, those providers then became motivated more to offer that treatment and to deliver it more successfully. So we've learned a lot that we can bring back to the United States. And peer support in non-traditional healthcare providers is really just the leading edge of doing that.
What about new technologies? We're in the age of AI, which is exciting and also a little frightening, but also whether it's new technology, we talked about telehealth, new treatments. What do you see on the horizon?
I think there's a lot of promise in novel technologies, AI, digital therapeutics, for two different purposes. One is to help the problem of matching treatments to individual patients, otherwise known as precision medicine, right? And we don't have that operant right now in psychiatry. Those of you in the room who've received treatment for mental illness know that it's a trial and error process, right? But if we can learn enough about our patients, get enough data on them, then we can use these approaches to develop tailored approaches that really work for individual treatments. That's a major thrust of our research. So that's one way. Of course, delivery of digital therapeutics is another way. And so there are tremendous opportunities for apps and other approaches that can augment clinical relationships with care providers and that can deliver that care to remote settings, rural areas, lots of different approaches, and tailor it also to individual patients in communities that are hard to reach. Now, I want to distinguish those kinds of approaches from wellness apps, from mental wellness apps. It's really crucial from my perspective as a researcher and as someone who wants to see these things implemented in the real world, that we study these apps and demonstrate that they actually work for people with mental illness, right? And that requires a certain level of regulatory oversight. That requires that these tech companies invest in their products to make sure they actually work so that doctors, patients, social workers, therapists can provide care that they know is going to work for their patients.
Do they work now?
Thanks. There are a few FDA-approved apps for mental health care. There's a lot of evidence, and there are some countries, learning from other countries, Sweden, that have adopted some of these evidence-based approaches, built them into their national health care plans, and some health care plans in the United States that are using these evidence-based approaches. But there are far more approaches that haven't yet garnered that evidence base that we really need to do.
As far as connecting to people, has, in the wake of the pandemic, has the stigma improved? Because people have to say, listen, maybe I do need to talk to somebody, and getting to that point, and that's a difficult process.
So asking me as a member of the public, yeah, I would say stigma has improved, right? I mean, we've all seen it in our daily lives. I would also say that that stigma was on its way towards improvement before the pandemic, but the pandemic greatly accelerated that process. As a researcher, I have to acknowledge it's harder for us to measure that. Okay. And we're not 100% certain the degree to which stigma has improved from a scientific perspective.
So you haven't seen the proof of that necessarily?
That's right.
Okay.
Let me just say that one measure of proof is the higher rates at which people are seeking treatment, right? And those waiting lists that we discussed, that we've heard about, the fact that it's really hard to find a care provider, that's all been increasing over the last decade, despite actually an increase in the number of care providers. It's not far enough, but there's increased demand for services. I would argue that's one one piece of evidence for that decrease in stigma.
As a key government leader, for people who are struggling right now, what would you advise to them?
Seek help. And I understand that help may not always be easy to get, and that's our cross to bear in terms of policymakers. We need to find ways to improve that. But there's lots of opportunities to reach out to trusted friends, family members, clergy, teachers, healthcare providers other than mental health care providers, and also, of course, the 988 National Crisis Line now. There are lots of ways to get help or reach out for it.
What does the research show on hotlines and how important, obviously, and the 988 hotline, I think, and I was saying this earlier, is one of the best ideas that government created.
So there's really good evidence that hotlines are an accepted and acceptable way to reach out for care. There is decent evidence, but not thorough yet, that reaching out to a hotline can help.
Okay.
And we need more evidence, really. Where we really need the research is on the back end. What happens after someone calls a hotline? What are the best approaches to use to back that up? We have some evidence for things like mobile crisis teams. We have a lot of evidence to suggest that we need mental health responses to mental health calls and not law enforcement, or for that matter, even your typical EMTs, right? So there's some evidence for some of the things needed to back this up. One of the things we're excited about is the fact that different states are doing different things in response to 988. And so we have researchers who are studying those different responses to figure out what works best. And once we know that, then we can tell everybody, hey, of all the different solutions the different states have implemented, these are the things that we're seeing actually move the needle on care.
So it's interesting. The states have little different methodologies.
Yeah.
And then you study them, see what works, and do that.
That's right.
Anything I didn't ask that you wanted to stress, or any closing statement from this, I think, very important discussion?
Well, one thing, you asked it and I sort of responded, but not explicitly. NIMH has been around now for 75 years. We're celebrating our anniversary. If you want to visit our website, lots of fun events to go to. There's a myth out there that research hasn't made a difference for mental health care. And not to minimize the evidence that we have a long way to go, that we're not making a dent in suicide rates, that there isn't good access, that most people aren't able to get evidence-based therapies. We have made a lot of progress, and a lot of that progress is because of research. We have dozens of medications for each of our mental illnesses. They're not perfect, they have tremendous side effects, but they can help people achieve recovery. Each and every one of those medications has been touched by mental health research. Cognitive behavioral therapy, psychotherapies for everything from autism to OCD, they all have a basis in research, either funded by or conducted at the National Institute of Mental Health. And so I think we have to acknowledge that research actually does pay off. And the reason why it's important to do that is because if we don't acknowledge that, then there's no incentive for policymakers, for Congress, et cetera, to continue funding that research. And we won't have the great discoveries of tomorrow that rely on it.
We've run out of time. Please thank Dr. Gordon for joining us. Thanks so much. Hey, that's great. Well done.
We have now come to the end of our program. Thank you so much, Bob and Dr. Gordon, and all the wonderful speakers this morning. It has really been a very compelling and moving program. On behalf of the Hill, and our sponsors, Otska, we'd like to thank everyone for joining us here and online. If you missed any portion of today's conversation or you'd like to review some of it, it'll be available shortly on thehill.com. And thank you all for joining us today.